blanking period and the difference between them. And if you're implanting a rate response pacemaker, then comes the sensor indicated rate. Let's say we are implanting a VVIR pacemaker in which you program a lower rate and you program an upper sensor or an upper activity rate, which denotes the maximum rate you allow the pacemaker to pace the patient's heart when he is maximally active, and you don't want the pacemaker to pace faster than that. And that's the upper sensor rate. And anytime when the patient is doing some moderate activity, then the rate delivered by the pacemaker, based on the input that comes from the sensor in the pacemaker, it will be anything between the lower rate and the upper sensor rate, so which can be called as a sensor indicated rate. So a nice way to remember, easier way to deal with this will be, you can think of the sensor indicated rate as the lower rate provided by the pacemaker at that instant of the time for that patient. So then the timing cycles will fall in place. It is nothing confusing here. So you only program a lower rate, you program an upper sensor rate, and any rate the pacemaker provides in between is a sensor indicated rate. And on what basis that it changes the rate? It is based on an activity sensor. The most common sensor that is used is a piezoelectric based crystal. In the older generation of pacemaker, this piezoelectric element was bonded onto the can of the pacemaker. And when the patient is walking or doing any physical activity, usually the arm is moved and the pectoral muscle also is moving. As a result of that, the can of the pacemaker gets slightly deformed. That vibrates the piezoelectric element which is bonded onto the can of the pacemaker. That generates mild electrical potential, which is also proportional to in frequency, which is also proportional to the activity the patient is doing. So this, by means of an algorithm, is converted into the rate at which we want to pace, which means higher the amplitude, more frequency, the rate will be higher. Lower amplitude, lower frequency will be a lower rate. So that's how it works. But this had a lot of problems associated with inappropriate rate response provided by the pacemaker. For example, when the patient is moving in a car or a bike in a pothole road, then it would provide a significantly higher inappropriate rates. Then in order to overcome that, the industry moved over to what is called as an accelerometer. It's essentially the same piezoelectric element, but it is not bonded onto the can, but it is suspended with a fulcrum on the circuit board. Now you can see this. This board can vibrate when the patient is moving in the anterior-posterior direction, and this generates electrical potential in amplitude and frequency, which will be proportional to the activity the patient is doing, which is converted into the rate at which we want to pace the patient's heart. So this is less likely to be providing any inappropriate rate response. Although this is not absolutely physiologic, then this is the best that mechanical rate response that we can provide. Although there are some physiological rate response options available, usually they are slightly slower to respond. So either they are not used, or they are used in combination with the piezoelectric mechanism. But in most pacemakers, this is the only one that is currently adopted in most company pacemakers. So coming back to the timing interval of the sensor indicated rate. So we program a lower rate interval, let us say 60 beats per minute, which is 1000 millisecond. And in this case, we programmed an upper sensor rate of 120 beats per minute. No matter how active the patient is, the pacemaker will not pace the patient's heart at a rate faster than 120 beats per minute. But all other activities, which is in between in its magnitude, between the lower rate and the upper sensor rate, the pacemaker will be providing a near appropriate rate for that patient to be paced, and that can be called as a sensor indicated rate, which, as I said one more time, you can think of this as a lower rate provided by the pacemaker at that instant for that patient. So that's the upper sensor rate and the sensor indicated rate programming. Then coming to some of the single chamber mode, you all, I'm sure, are familiar with the VOO mode, which means the pacemaker will be all the time pacing and disregarding any intrinsic activity that's going on, because it's not, this mode does not sense at all. So you typically use this when your pacemaker implanted patient may have to undergo a surgery where the surgeon is likely to use a cautery. And another option is available when you keep a magnet on the pacemaker. There is a switch which converts it into a VOO, or if it is a dual chamber, into a DOO mode. And so that's what this. So as you can see here, there's an intrinsic activation that happens in the patient's heart on its own, but that is not sensed because it's VOO and it goes on pacing all the time. But there is a remote risk at some time that this V-pace might fall on the T wave in some patients where they are vulnerable for a ventricular arrhythmia. That has a small risk of triggering a ventricular arrhythmia, which has to be kept in mind. That's why when you want to use a VOO mode or a magnet mode, then the rate should be programmed, and the magnet rates are usually significantly higher than the conventional lower rate that are programmed, which will generally take care of the competitive pacing that might happen. And the timing cycle might look like this. Although the pacemaker will be sensing the electrogram, actually, here in order to explain in relation to the ECG, we have sketched the actual ECG itself, but keep in mind that the pacemaker senses the tip to ring intracardiac electrogram. So V-pace, it starts a low rate timer, and at the end of it delivers V-pace. Disregarding an intrinsic activation that might happen, there is no V-sense happening. So that's VOO. Against this, VVI, we already discussed, it's V-pace starts a low rate clock, and if there's an intrinsic event, then it senses and it resets the clock. But both during V-pace and the V-sense, it also starts its own refractory period. The first portion of that is a blanking period. And the reason why we have is what we discussed already. And the ladder diagram might look like this. And if you recall the VOO mode, here there's a ventricular ectopic, which is happening outside the refractory period, which is sensed by the pacemaker, and it resets the lower rate clock here and delivers a V-pace at the end of that cycle. And what happens if there is a refractory event that happens? In this case, the first one is a ventricular ectopic that's happening outside the refractory period, which is a sense, V-sense, outside the refractory, so it resets the lower rate clock. But here, there is probably an electromagnetic interference sensed by the pacemaker that falls inside the refractory period. Although it's sensed, it calls it as a refractory ventricular sense. And note here, it doesn't reset the lower rate clock. But had it reset, then my V-pace would have happened somewhere here. That might be a true bradycardia for that patient, because that pace will be from this V-pace to here. So this in a way helps if there is an electrical noise happens, or if there is a T wave oversensing, that might happen. So if there is a continuous electromagnetic interference, that might happen. So repeated noise that falls within the refractory period, as we discussed a couple of slides back, will start one more refractory period. If there is one more noise before the expiry of that refractory period, it starts one more refractory period. But by this time, the lower rate times out, it paces the ventricle. So this is also referred to as a noise reversion happening in a pacemaker because of the continuous oversensing that happens. So that's the noise reversion that might happen. So that is one thing that might happen. So we may think that there is noise going on and the pacemaker is still pacing. So this can be sometimes observed. And this might happen even during ventricular tachycardia. If it is fast enough to, the RR interval is short enough to fall inside the refractory period, then when there is a ventricular tachycardia going on, the pacemaker might continue to be pacing, although there's a VT that's going on for the patient. That's not due to real undersensing, that was due to the behavior of the refractory period of the pacemaker. Right, so the other problem occasionally that you may see in a pacemaker is a T wave oversensing, which is, as the name suggests, oversensing of the T wave of the intracardiac electrogram. And if it is outside the refractory period, then it resets the lower rate clock. Ideally, by the lower rate clock, then I would have wanted to pace the patient's heart here. But because I'm pacing, let's say 300 milliseconds later, if your lower rate is 60 and the interval is 1000 millisecond, then we are actually pacing the patient at the rate of 1300 millisecond, which could be bradycardia for this patient. So that is T-wave oversensing that is there. But oftentimes, if there is a T-wave oversensing, it might fall within the refractory period. Usually, we don't see a reset of the clock. And in the older generation pacemakers, observing a T-wave oversensing is pretty rare, but it is often seen in an ICD and the modern pacemakers, which all companies are gradually shifting to, which is built on an ICD platform where the refractory periods are shorter or it doesn't exist at all. So that might happen occasionally. So in which case we may want to reduce sensitivity. One option here is we can reduce sensitivity, or you could increase the refractory period to cover this so that it doesn't reset the lower rate clock. And then we already discussed about the sensor indicated rate. Then if it is VVIR pacemaker, then we program a lower rate and the upper sensor rate. And when the patient is maximally active, the pacemaker paces at the upper sensor rate at all times, anything between these two. And when the patient is totally at rest, the pacemaker will be pacing at the lower rate. So that's VVIR or an AAIR if you are implanting a AAI pacemaker, which you may rarely consider implanting if you are sure that the patient has a good AV conduction, and then that's more physiological to pace this patient with the AAIR mode. And that, of course, the lower rate and the timing cycles are exactly the same as it is for the ventricle, except for the refractory period, which is usually longer to avoid oversensing of the far field R wave, which we'll discuss about what it is. And the other single chamber timing cycle is what is called as hysteresis. So what it means is that it has two timing cycles that is running. One is the lower rate interval, which on every time the pacemaker paces, it starts the lower rate clock, in this case 1000 millisecond, based on our low rate of 60 beats per minute. And we have also switched on a hysteresis rate for this patient, and we programmed the hysteresis rate to be 50 beats per minute. So that means on sensing, the pacemaker will not start a lower rate clock. It will start a hysteresis rate clock, so that this clock will run for 1200 millisecond according to this rate. And if there is one more V-sense that happens before the expiry of 1200 milliseconds, let us say at 1100 millisecond, which will be a rate of 55, then it will start one more hysteresis cycle, which means that this pacemaker is now allowing a rate which may be physiologic for this patient, which will be lower than the lower rate. So this will be useful if you are implanting a single chamber ventricular pacemaker, probably for a sinus node dysfunction patient or intermittent AV block patient, where when you pace, you want to pace at what you think is appropriate for the patient. But when the patient has an intrinsic activation, you want to allow a slightly lower rate, which could be physiologic. So at this point, I would like to pause and request Dr. Raja's comment on any of these aspects. The hysteresis, some clinical relevance, and also usage of the VOO or the magnet, sir.
So I just think, I'll not comment on any particular aspects now. I think we can finish, and we can, once there are questions, we can see the discussion. But okay. But basically, throughout, when you see pacemakers and especially pacemaker follow-ups, timing cycles are the most important aspect to understand. And again, as you come to newer devices and different algorithms and all that, but still, I think finally it's the single chamber timing cycles which form the basis for everything. So it's good that you've gone in detail with that. So there might be doubts with some of these things. I think sometimes people have confusion with some of these issues. Hopefully, when there are questions and feedback, we should be able to identify that and discuss it further. I think we can do it together in the end, I think.
Sure. Okay, I'll go ahead. So we'll go ahead with the dual chamber timing cycles, which will be DDD or DDDR. Essentially, a dual chamber pacemaker can pace in 4 different combinations. One is, it could be AV sequential. It is A pace, V pace. which provides AV synchrony. And then at the expiry of the lower rate interval, it delivers another A pace and B pace. So that's the AV sequential pacing. And another way is that you have given a dual chamber pacemaker for a patient that has a sinus node dysfunction with intact AV conduction or intermittent AV block, in which case, based on the current clinical evidence, you may not want to pace the ventricle. So in which case, you set your AV interval in such a way that it allows intrinsic AV conduction to take place. So ventricle gets activated intrinsically. So in this case, it is A pace, and before the expiry of the AV interval comes the intrinsic ventricular activation, which is sensed by the pacemaker. So it's A pace V sense sequence that will go on. And if you look at only the ECG, it will look more like a AAI pacing that's going on, because you will be seeing A pace that goes on. This will be more physiologic for your patient. So this is the functional AAI pacing, if you can call it as one. And then the most common one that we observe in our country is that patient has a normal sinus node function, or at least a near normal sinus node function, and then a permanent AV block. So in this case, we may want to pace the ventricle. We have to pace the ventricle all the time. The patient's sinus node function may be normal. So in which case, we don't want to pace the atrium. So you program a lower rate sufficiently low to allow intrinsic atrial activation to be sensed by the pacemaker. On sensing, of course, it will start the lower rate, the AV interval. And because the patient is an AV block patient, it delivers a V pace at the end of the AV interval. So this, like the other two sequences, it also provides AV synchrony. But the additional advantage of this is that in a patient that has a normal sinus node function, without making use of the pacemaker's mechanical rate response, you are leveraging the patient's own sinus node based natural rate response, which will be more physiological and appropriate for this patient. So this is functionally a VDD mode, right? So we are not pacing the atrium. So in a patient that has a normal sinus node function, then a functional VDD or a dedicated VDD will not only provide the AV synchrony, it will also provide the most appropriate rate response for your patient. So for a patient that has a normal sinus node function, even if you want to give the best DDDR pacemaker, it might be good to consider programming that into a DDD mode to leverage the activation of the normal sinus node function to provide a good rate response for that patient in addition to AV synchrony. And of course, you do get to implant a dual chamber pacemaker for a patient that has intermittent bradycardia. Then you want to program it in such a way that you pace it only when it is absolutely necessary, but at all other times, you want the intrinsic activation to be prevailing. So in which case you program a lower rate low enough so that it doesn't pace the atrium, and you program an AV interval long enough to allow the intrinsic AV conduction. So it will be A sense, B sense. So this on the ECG will look like a normal sinus rhythm that's going on for this patient. So these are the 4 different ways a dual chamber DDD mode can pace. So this has timing cycles, which we will consider in the next few slides, which also has just like a single chamber lower rate corresponding to that a lower rate interval. And it has AV interval, and then there is a VA interval. We'll discuss about that. And sometimes interesting and sometimes confusing, upper tracking rate and the upper tracking rate interval, and additional refractory and blanking periods, and the upper rate behavior as well. The lower rate in a dual chamber pacemaker is almost the same as the single chamber, but the only difference is that in the current generation of pacemaker, it's all atrial based lower rate interval. So the lower rate is reference to atrial channel. So there are 2 channels. One is the atrial channel and the ventricular channel. You can actually reference the ventricular channel to calculate our lower rate interval, but all the companies today have moved over to the atrial based lower rate timing. So it's A pace to A pace when it comes to lower rate interval in a dual chamber pacemaker. So on delivering an A pace, it will start the lower rate timer in the atrial channel, and at the end of the interval, it will deliver an A pace again. And if there is an intrinsic atrial activation before that, it will be ascends and will restart the lower rate interval. So it will be essentially A pace to A pace or ascends to A pace, and there will be a little variations that we will discuss about that. So that's the lower rate interval. And then you may have to program an AV interval. So in this, there are two AV intervals. One is a paced AV interval and a sensed AV interval. A paced AV interval is the one that starts after a pace, and a sensed AV interval is the one that starts after a sense. And it's a convention to program a sensed AV delay to be about 30 millisecond or 50 millisecond shorter than the paced AV interval. And one more point to notice, the AV interval duration in the atrial channel is also a refractory period. On delivering a pace, the AV interval starts, that's a refractory period in the atrial channel. And the reason why do we want to have this little bit of a difference, the shorter sensed AV interval and a slightly longer paced AV interval, is this: your lead is placed usually in the appendage, and if the patient has intrinsic activation which begins at the sinus node, and by the time part of the atrium is depolarized and the impulse reaching the appendage for the atrial lead to be sensed, about one half of the atrial depolarization is already over. So if we want to set an AV interval which is the same both after pacing and also sensing, then we need to account for this difference. So if you are pacing the atrium from the pacemaker, then the activation starts on pacing, but on sensing, half the activation is already over. In order to account for this little bit of time difference, the sensed AV interval is programmed conventionally about 30 milliseconds shorter than the paced AV interval. And physiologically, it might not make a big difference if you really program both of that same, or even sensed AV delay slightly longer than the paced AV interval, but that's how it is programmed. And in the current generation pacemakers, the sensed AV delay, the nominal value will be 150 millisecond and the paced AV delay will be 180 millisecond. And in the slightly older generation, it is 120 and 150 millisecond. And that's the AV intervals, and then how they are programmed. And then the next interval becomes the VA interval. In the current dual chamber pacemakers, because the interval is based on the atrial channel, the VA interval is not a programmable interval. In a dual chamber pacemaker, we do program a lower rate and we program an AV interval. So in this example, the lower rate is 60 beats per minute, which is 1000 millisecond, and we have programmed an AV interval of 200 millisecond. And in this case, the VA interval happens to be 800 millisecond, which is 1000 minus 200 millisecond. But assume that this patient had an intrinsic AV conduction time, AV conduction happening, and that happened at, let us say, 100 millisecond. Then the AV interval gets cut short at 100 millisecond. The VA interval automatically becomes 900 millisecond. So this is how it is derived, and it dynamically changes depending on the status of the AV conduction of this patient. So that's not a programmable value, and sometimes it is referred to also as the atrial escape interval. So that's the VA interval. But what happens if there is a VPC? So all the time we've been discussing about the nice sequence of ascends V-pace or A-pace V-pace. Here is a PVC happening for this patient. On A-pace, it started a lower rate clock. We have a 200 milliseconds AV interval. It delivered a V-pace. And now the lower rate clock is running here. Now, we said our timing is based on the lower atrial channel, but now there's a VPC happening. So on VPC, then the pacemaker actually for that beat shifts to a ventricular based timing. So on VPC, it actually, it senses, it becomes a V sense. Now it starts a real VA interval. In a free running DDD mode, it doesn't restart a VA intervals. Here it starts a VA interval. In this case also, the VA interval will be the lower rate interval minus the AV interval. So at the end of the VA interval, it will deliver a pace. If we do not do that, my lower rate might run out here, then we would deliver a pace at this point of time. So in order to avoid that, the pacemaker for this beat alone, whenever there is a PVC, it will shift to a ventricular-based interval, and it will actually start a VA interval. At the end of VA interval, it will deliver a pace. And of course, the next free running will start with the AV interval that goes on. So that's the behavior when there is a PVC happens. And the other one that we need to program in a dual chamber pacemaker is the upper tracking rate. So why do we want to do that? Your patient may have an atrial tachycardia. If you do not set a limit for pacing the ventricle, then on sensing a faster atrial rate during atrial tachycardia, it would pace the ventricle also at a very fast rate. So we don't want that. So then you want to put a limit to that. And also, if there is an inappropriate sinus tachycardia or even appropriate sinus tachycardia in a patient who may have a coronary artery disease, you may not want to pace the ventricle at fast rates. So that's the reason for the upper tracking rate, which means that the maximum rate ventricle can be paced in response to sensed atrial event. So that's what the upper tracking rate is. So in this example, there is a lower rate that we have programmed. And then, of course, there is an AV interval on sensing the atrium. In this case, the patient's sinus rate is going on, which is a little faster. And on sensing the atrium, the pacemaker starts a sensed AV interval. At the end of the sensed AV interval, it delivers a V pace. And the upper tracking rate interval, unlike a lower rate interval, is a ventricular-based timing. So it starts in the ventricle. So here it starts the upper tracking rate interval. In this case, we programmed an upper tracking rate of 100 beats per minute, which means in this case, we don't want to pace the ventricle at a rate faster than 100 beats per minute in response to atrial sensing. So it starts that interval on ventricular pacing, and that clock runs in the ventricular channel. Look here, it is the ascends. Now this rate is faster than 100 beats per minute. It, of course, is sensed. It starts an AV interval. At the end of AV interval, it is expected to deliver a V pace here. Because we programmed an upper tracking rate of 100 beats per minute, which is an upper tracking rate interval of 600 millisecond, the pacemaker will not deliver a V pace here. It will wait for the upper tracking rate interval to time out and then only pace here. So here there is an increase or an apparent increase in the AV conduction, AV interval for this patient. So this is the basis for the upper rate behavior. We will discuss in more detail as we go along. So that's the upper tracking rate interval, which is the ventricular paced interval. And then when it comes to atrial tracking, as we said, you are tracking the atrium. So it's more like a functional VDD pacing, even though you may have a DDD pacemaker. When the patient is at rest, when the sinus rate is low, it's ascends V pace at a fairly low rate. When the same patient is having a higher sinus rate, either because of physical activity or any other physiological reason, then the sinus rate increases, then it's going to track that faster rate by sensing the atrium on every beat and paces the ventricle at a faster rate. So this is the reason why the functional VDD in a normal sinus node functioning patient will provide appropriate rate response as well. So that's the advantage of the tracking the atrium in a normal sinus node patient. And that's a programmable rate. And there is a nominal setting of 130 millisecond, 130 beats per minute in the current pacemakers. And you could program it to a higher upper tracking rate if it is a physically active and a younger individual. But for a patient that has a coronary artery disease or an elderly person where you may want to limit the ventricular pacing rate, then you may want to program a slightly lower upper tracking rate when the patient is having an AV block. Of course. And then there are more refractory periods and blanking periods. As we said earlier, remember that there are two electronic channels that run in the pacemaker, one in the atrium, one in the ventricle, and then they may interact with each other. We will see some of this. There is a ventricular refractory period, which is exactly the same as what we discussed in the single chamber ventricular pacemaker timing cycle. On V pace or V sense, that refractory period starts, which is a programmable one. And here is an ECG where there is a pacemaker mediated tachycardia is happening. Here, the patient is having sinus rate going on, with AV conduction also going on. So A sense, V sense, A sense, V sense. There's one ventricular ectopic that allowed a retrograde activation of the atrium, which is sensed by the pacemaker. It starts an AV interval, delivered a V pace. That resulted in yet another retrograde activation. So that becomes a A sense in the atrium because it's a retrograde activation in the atrium. That starts one more AV interval, V pace. So this cycle goes on theoretically endlessly. So this is what is pacemaker mediated endless loop tachycardia that goes on. So unless we interrupt, this can go on forever. So that's the problem that can be associated with a dual chamber pacemaker if there is a retrograde activation that happens. So we don't want that to happen in a pacemaker patient, and that's why there is post-ventricular atrial refractory period, which you all know it as a PVARP. So on ventricular pacing, in the atrial channel, it starts a refractory period, which is a cross-chamber refractory period. On V pace or a V sense in the atrial channel, which is a programmable value. In case there is a retrograde activation and the retrogradely activated P wave is likely to fall inside that refractory period, because it's a refractory atrial sense, the pacemaker will not trigger an AV interval, so no ventricular pace. So this will prevent the start of the pacemaker mediated tachycardia right in the beginning itself. So that's the reason why we have a post-ventricular atrial refractory period. That also has a little relationship with the upper rate behavior. We will discuss about that as we go along further in this presentation. So that's PVRP, which is a programmable value. And then now putting together the AV interval and also PVARP. On A sense, there is a AV interval. In this case, it's 200 millisecond. And on V pace, in the atrial channel, we have started another refractory period, which is PVARP, which is 300 millisecond. So for a continuous period of, which is a total of sensed AV and PVARP, which is 500 millisecond, the pacemaker atrial channel is refractory. Which means, according to this setting, if this is what our setting is, if this patient has a sinus tachycardia at a rate faster than 120 beats per minute, the P to P interval might become less than 500 milliseconds. So the next sinus P wave might fall inside the refractory period, which we do not want. So while PVRP is useful for preventing pacemaker-mediated tachycardia, if it is long, then we may have the sinus event itself falling inside this, which will not be tracked, which is not desirable. And we will see how it is overcome also in the later slides. So that's the PVARP and its relation to the total atrial refractory period. And this is an example of a pacing spike being oversensed in the ventricle. Dual chamber pacemaker, A pace, V pace sequence is going on. Here there's a A pace that we can see, but we do not see a ventricular pacing spike, nor do we see an intrinsic QRS. So the fact that there is no ventricular pacing spike means that the pacemaker has sensed something, but that should ideally be an intrinsic QRS. But the fact that we are not seeing an intrinsic QRS means that there was an oversensing that happened here. So the most likely oversensing that could have happened here is the oversensing of the atrial pacing spike in the ventricular channel. And ventricle says that, okay, that's a ventricular activation, so it gets itself inhibited, no pacing happens. That is the crosstalk, which means the pacing pulse being oversensed in the opposite chamber is called as a crosstalk usually. And then there is another thing that might happen, and this is actually a strip from one of the modern pacemakers, where actually there can be a far field sensing. What the top channel that you're seeing is the atrial channel, and this one is the ventricular channel, atrial electrogram and the ventricular electrogram. And here patient seems to be in sinus tachycardia or an atrial tachycardia, A sense, V sense going on. But from this point onwards, you can see here, there is the A sense, V sense. Along with that, there is one more sense marker count. And if you carefully see the electrogram corresponding to that, there is one electrogram, and consistently that falls above the R wave. This is what is the far field R wave that can be seen by the pacemakers. right? Ideally, we don't want this. So if we allow the pacemaker to see this all the time, now for the pacemaker, this is a probable atrial tachyarrhythmia, and then the device will behave slightly differently than how it behaves in a dual chamber mode. So that this is what is called as far field R wave oversensing. That's a little bit of a nuanced difference. One is a pacing spike in one chamber being sensed in the opposite chamber is technically a crosstalk, and intrinsic activation sensed in the opposite chamber is called as a far field sensing. The most common ones are atrial pacing spike being oversensed in the ventricular channel, and the R wave being sensed in the atrial channel, which is far field R wave. So although these two terminologies are sometimes interchangeably used, this is the difference. We don't want both of this. We don't want the atrial pacing spike inhibiting the ventricular channel, nor do we want an R wave or even a paced R wave being oversensed in the atrial channel. And the pacemaker erroneously thinks that it's an atrial tachyarrhythmia that's going on, and it'll give erroneous diagnostics, and the mode also might change, as we will see later. We don't want that. In order to prevent that, the pacemaker has a little blanking after a pace in the ventricular channel. This is the refractory and blanking in the atrial channel. This is the refractory and blanking in the ventricular channel. You need to mentally have a picture of this one if you want to easily troubleshoot. This is all you need to keep in mind, in addition to the timing cycles. On a pace, it starts an AV interval in terms of timing cycles, and that we said is a refractory period in the atrial channel. The first portion of that is the blanking period, that's in the atrial channel. But on a pace, we want to avoid the crosstalk inhibiting the ventricular channel. That's instantaneous, so there is a very short programmable blanking period. The oversense will fall inside this and it will not inhibit the ventricular channel. It is rare in the current pacemakers to see this. Right, so that's the blanking. That's the post-atrial ventricular blanking. And then here on ventricular pacing, there is a ventricular refractory and the blanking. And in the atrial channel, it starts PVARP, which we discussed about. And in order to avoid oversensing the far field R wave or even the crosstalk, then there is a programmable blanking here. So these two are cross-chamber blanking. And then these are the same chamber blanking. In the current pacemakers, usually the same chamber blanking are not programmable, which automatically adjusts. The cross chamber blanking are usually programmable. So if you have, in addition to the memory of the timing cycles and a mental picture of this blanking and refractory, you will be able to troubleshoot most of the pacemaker problems. So this is an important aspect that you have to keep in mind. So this is the refractory and the blanking period. And this is a picture from one of the slightly older generation pacemaker, where there is a electrogram that is picked up as a ventricular high rate episode. You see the ventricular electrograms, the larger electrograms are the ventricular electrograms, and you also see the smaller electrograms in the same channel represented here. Those are the atrial events. You see here, some of them are actually not being sensed in the atrial channel. Sometimes it is sensed as a sense or a AR, but sometimes it is not sensed. Why it is not sensed? Because it's falling inside the blanking. So this is a functional undersensing. It's not a real undersensing that's going on. So you may want to keep that in mind when you actually see some atrial undersensing that happens in a pacemaker. That could, some of these atrial events, when the atrial rate is truly faster, might fall in the post-ventricular atrial blanking. That's about the blanking and the refractory periods. And we will see quickly some of the dual chamber modes and their timing cycle. Of course, there is a VOO mode, in which case it will disregard any intrinsic activation. It will go on doing A pace, starts an AV interval, do a V pace, and on A pace it starts a lower rate interval, deliver A pace, and then the AV interval V pace. So that's an AV sequential VOO pacing that will go on. And you may want to use it only in a patient, as we said, that has to undergo a surgery where an electrocautery is used, or you can use alternately a magnet can be placed on the pacemaker. And this is a VDD timing. On A pace, it starts a lower rate interval in the atrial channel. and it starts the AV interval, which is a refractory, and the first portion of that is the blanking. And on A pace in the ventricular channel, there's a post-atrial ventricular blanking to prevent crosstalk from inhibiting the ventricular pacing. So at the end of the AV interval, the pacemaker delivers a V pace, ventricular refractory and blanking, and then in order to prevent the pacemaker-mediated tachycardia or the far-field larvae, there is a PVARP and the post-ventricular atrial blanking. So that's the DDD timing in AV sequential pacing, in A pace, V pace that goes on. And the other one is, yes, if you have given a pacemaker for intermittent bradycardia patient, where there is need for pacing occasionally, then ideally you program the lower rate low enough and the AV interval long enough to allow intrinsic activation to take place. So here, because the lower rate is very low, we are sensing the atrium, because since the atrial event is faster than the lower rate that we program. On sensing, it starts an AV interval. Before the AV interval expires, AV conduction happens, so the ventricular intrinsic activation is sensed. Note here, on a sense in the ventricular channel, there is no blanking. So this blanking in the ventricle kicks in only when there is a pace, the post-atrial ventricular blanking, because the atrial sense event, intrinsic P wave being sensed in the ventricular channel is very, very rare. So that is not incorporated. So that happens only on an atrial pace. And the rest of the timing actually happens the way that it is in the AV sequential pacing that we talked about. And the other one, patient has a sinus node dysfunction, intermittent AV block, but most of the time AV conduction is happening, which will be doing APVS, which will be functional AAI pacing. A pace we sense is what is going on here. And on A pace, there is an AV interval, and that's programmed long enough to allow the intrinsic ventricular activation. Note here on A pace, there is a ventricular short blanking to prevent the crosstalk from inhibiting the ventricular channel. All the rest of the timing runs as we described before. That's a functional AAI mode. And the other one is the normal sinus node patient with AV block, which we briefly described earlier. So the timing will run like this. A sense, you programmed whatever AV interval, patient is an AV block patient, no matter how long the AV interval is going to deliver V pace, and the rest of the timing cycle goes on like this. So this maintains AV synchrony and also provides patient's own intrinsic rate response, which is appropriate for this patient. So there is another mode, which is DDI mode. So this comes into play when the patient has atrial arrhythmia. When the patient has an atrial arrhythmia, there is one defense you already have by programming the upper tracking rate to not pace the ventricle at a faster rate. Then ideally, we want to disengage tracking at all times if the patient has atrial arrhythmia. So that's what the DDI mode does. So this is different from DDD mode, where we said in a DDD mode, the basic timing is based on the atrial channel, whereas in a DDI mode, the timing is based on the ventricular channel. So now you can see that as I described the timing cycle, it will not be tracking the atrium. As a result of that, you will not be tracking the faster atrial tachyarrhythmia to pace the ventricle, which means we disengage atrial tracking. So here, the lower rate is based on the ventricular channel, unlike in a DDD mode. On V pace, it starts a lower rate interval. At the end of the expiry of the lower rate interval, it delivers a ventricular pace in the ventricular channel. Right? So along with that, it also starts with the lower rate, the VA interval. Remember, in a DDD mode, we don't start the VA interval. We only start the AV interval. Here, it starts the VA interval. And while the VA interval is running, if there is an intrinsic atrial activation happens, it ascends and keeps quiet. It does nothing at all. But if there is no intrinsic atrial activation happens before the expiry of VA interval, it will deliver a pace. So look at this one, what happens? The VA interval is running. While VA interval is happening, there is an intrinsic atrial activation encountered by the pacemaker, which is ascends, which is outside the refractory period. In a dual chamber DDD mode, it would have started an AV interval. But DDI, remember, this is only I. It does not have a T. It does not trigger an AV interval. So it does not trigger an AV interval. So there is no ventricular pacing here. So we are not tracking. We are not tracking this. So it disengages tracking of the atrium. So on sensing, it just keeps quiet. It does not deliver the A pace. But in this case, there is no A sense, so it delivers an A pace. So that's a little difference between DDD and DDI. You can imagine DDI to be exact opposite of DDD, where it starts a AA interval and then a AV interval, whereas a DDI, it starts a VV interval and a VA interval. Then all things will fall in place, which need to be programmed if your patient has a chronic atrial arrhythmia. Then the current pacemakers shift to this mode on detecting an atrial arrhythmia. You will program the pacemaker to a DDD or a DDDR mode. And when the patient is having normal sinus node function or atrial pacing going on, it'll be A sense V pace or A pace or V pace that will go on. But suddenly when the patient gets an atrial arrhythmia, it will be detected based on the faster atrial rate detection, and the device mode switches to DDIR mode, which means it's no more tracking the atrium, and the ventricle will be paced at the lower rate or the sensor indicated rate. So it will not track the faster atrial rate at a faster rate in the ventricle. So that's DDI or DDIR mode. Right, so the other one is the VDD mode, which we already discussed about it. So which means in VDD, we are not pacing the atrium. We are only tracking the atrium and pacing the ventricle on sensing the atrium. The point that you may want to remember is, if you want to program a VDD mode in a DDD pacemaker, or if you want to give a dedicated VDD pacemaker, then one consideration that you need to keep in mind is your patient should have a normal sinus node function. One of the reasons why you want to give a VDD mode in most of our patients is you want to give a slightly less expensive pacemaker. You consider that I'm going to track the atrium and pace the ventricle. But if this patient also has sinus node dysfunction and frequently goes to sinus bradycardia, then you are defeating your own objective by giving a VDD for such a patient. You have given a costly VVI pacemaker, and this is what happens here. Here on A-sense, I'm tracking and pacing the ventricle. A-sense, I'm tracking, pacing the ventricle. Here, because of probable sinus node dysfunction, there is no intrinsic atrial activation happening. But here, the timing, unlike the DDD mode, is ventricular based. So on pacing the ventricle, it started a lower rate time in the ventricular channel, and it did not see an atrial event. So at the end of lower rate timing, it just paced the ventricle. And had it seen a V sense, it would have started an AV interval, paced the ventricle. That would have been an AV synchronous. But here, because there was no atrial sense, in this case, there was no atrial activation. So it behaves just like a VVI pacemaker. So also here. So if you are giving a VDD mode or a VDD pacemaker, you need to keep in mind the patient should have a normal sinus node function. If the patient has a normal sinus node function, if atrial sensing is adequate, then it's a great mode to give to your patient. So that's the note on the VDD mode. And then the other mode that is available now is the MVP mode, which is managed ventricular pacing. Based on the current clinical evidence and the current practice, you want to minimize ventricular pacing when the patient has AV conduction, although patient may have a slightly prolonged PR conduction times. So MVP eminently achieves that. In the conventional pacemaker, you cannot program a AV interval beyond a certain limit. Then if you program it that way, if the patient goes into an AV block, at a long PR interval, you end up pacing ventricle that might allow a retrograde ventricular activation, which may predispose a patient for getting the pacemaker mediated tachycardia. So this MVP mode gives the benefit of AIR mode of pacing, but at the same time, when it has to pace the ventricle, paces at the optimal AV interval. So this is how it behaves. So MVP, ideally you have programmed it to a DDD or a DDDR mode. We call it as MVP mode. and now it is functioning in the AAI, phase of the MVP mode, which means on a sense or a pace, it of course will not start an AV interval. It is remaining in an AAI mode. No matter what is the length of the AV conduction time, it will allow that. So it will always be A sense, V sense, and on a pace, the PR conduction time prolongs, it still allows that. So it will be kind of AAI pacing that's going on. But while this is going on, if the patient loses AV conduction at some point of time, the pacemaker will wait for, or this timing cycle will wait for one full AA interval without delivering a ventricular pacing. If it is a dual chamber mode, at the expiry of the whatever AV interval that we programmed, it would have delivered a V pace here. But it will wait for one full AA cycle without a ventricular pace. And there is no ventricular intrinsic activation also. But at the end of that next A pace, it will deliver a backup ventricular pace. It is still in AAI mode. It only delivers a backup ventricular pace. But from the next cycle onwards, AV conduction continues, so it continues to remain in AAI mode, AAI phase of the MVP mode. But if the patient goes into a persistent AV block, which is defined as 2 AA interval without a ventricular intrinsic activation, and the pacemaker had to deliver a backup ventricular pace. So for the pacemaker, this is a persistent AV block. Then the pacemaker will switch to a DDD mode. And here, note here the AV interval is allowing a long AV conduction time. Here, it's a programmed AV interval because the device has already switched to a DDD mode. So it's A pace, V pace, A pace, V pace. But here, when it is pacing the ventricle, it's in an optimal AV interval that you have already programmed. That need not be a longer AV interval. So this is what is going on. Now the pacemaker, after seeing a persistent AV block or evidence of persistent AV block, switched from the AAI phase of the MVP mode to a dual chamber mode. But right after this, a few weeks later, the patient might get AV conduction back, and that could be a longer AV conduction time. So with this AV interval, the pacemaker will not know this. So in order to know this, after some time, the pacemaker will shift for 1 beat to a AAI mode, as you can see here, which is usually 1 minute after the last switch. Then in this case, it finds AV conduction and goes back to AAI mode. But if it does not find an AV conduction, then it will attempt to do the same at 2 minutes, 4 minutes, 8 minutes, in that progression all the way up to 16 hours. If your patient has gone into a permanent or persistent AV block, every once in 16 hours, now it is in a DDD phase of the MVP mode. Once in 16 hours, it will try to go to AAI mode to look for AV conduction. If it finds AV conduction, it will go back to AAI mode and allow intrinsic activation, which could even be longer. So this way, in a patient that has intermittent AV block, intact AV conduction, although it could be a long PR interval, you will not end up pacing the ventricle. So that's the advantage of the MVP mode. And here in this case, while the pacemaker is switching from the dual chamber DDD phase of the MVP mode, A sense V pace is going on, it is attempting to go back and looking for an AV conduction. So in this case, there is no backup ventricular pacing. So one full AA cycle is allowed without a ventricular even. Here it did not find an AV conduction, so continues to remain in a DDDR mode. And it will attempt it 2 minutes later, 4 minutes later, like this. And if it finds an AV conduction, then it will go back to AAI mode. By repeating this cycle, every time it finds AV conduction, irrespective of the length of the AV conduction time, it will not pace the ventricle unnecessarily. You can greatly minimize ventricular pacing. That's MVP mode. Okay, so then I'll carry on because of time, and also, we decided that we'll take the question at the end of it. So this, I'm sure you recognize already. This is actually a CRT, basically, as you can see here, biventricular pacing annotation, but the timing cycles are all the same. But there's a nice strip that I got. So it's ascends, bipace, ascends, bipace going on. Suddenly you find one P wave not being tracked. And also, if you carefully see, the PR interval is gradually prolonging. This looks like the intrinsic Venn-Kebab behavior. This is what the pacemaker Venn-Kebab that can happen. We'll see why it happens. And if the sinus rate becomes even faster, then this pacemaker can go into a pacemaker 2:1 block. Although it's a CRT, the timing cycles are the same, and then we'll see why that happens. That is because of what we call as the upper rate behavior, and this is the behavior of the pacing function when the sinus rate is faster than the programmed upper tracking rate and what TARP that we have programmed, which is a combination of AV interval and the PVARP that we have programmed. We already saw this diagram before. In this case, the TARP is 500 millisecond. We also said that because the TARP is 500 millisecond, if the patient has a sinus rate faster than 120 beats per minute, the PP interval is going to be shorter than 500 millisecond, and the next P wave might fall here, which would not be tracked. And if the patient has an AV block, then there will be no ventricular pacing that's happening. So that's how the 2:1 pacemaker block happens. To explain here, this patient has a sinus rate of 130 beats per minute, which is a PP interval of 450 millisecond. So there is a lower rate on ascents that started by the pacemaker. And this patient is an AV block patient. On ascents, it started an AV interval. In this case, we have programmed an AV interval of 200 millisecond. At the end of 200 milliseconds, it delivers a V pace. And also the PVRP is programmed to 300 millisecond. And on V pace, the pacemaker starts an upper tracking rate, of course. And in addition to that, in the atrial channel, it starts the PVARP. Now, the PP interval is 450 millisecond. So this is shorter than 500 millisecond. So the next sinus event is falling within the PVARP. This is a refractory atrial sense, marked as AR. It does not start an AV interval. So there is no ventricular pace. And then the next sinus event actually happens well after this, which is at the same 450 millisecond, which is sensed by the pacemaker, and it starts an AV interval and delivers a V pace. And of course, this starts its own PVARP, and the next P wave will fall inside that because this PP interval is one more time is 450 millisecond, just like this one. So this, I'm sure you recognize, P wave followed by a QRS, one P wave not resulting in a QRS, next P wave followed by a QRS, next one not resulting in a QRS. So this is alternate ventricular pacing, which is equivalent to the pathological 2:1 block that you see in a pacemaker, but this is coming because of the interaction of the pacing timing cycle. So this is a pseudo 2:1 block or a pacemaker 2:1 block. So if you want to track this, then I want to program the PVARP shorter than this 450 millisecond. So this will come outside the PVARP, then the pacemaker will track this. So if you're looking at the ladder diagram, this is how it might look. Ascents, at the end of AV interval, we deliver a V pace, and the patient's sinus rate becomes slightly faster, and it's an AV block patient. So this P wave is falling inside the PVARP. That's not starting an AV interval, no ventricular pacing. And when the sinus rate remains slightly faster at this rate, then alternate P waves are falling inside the PVARP, not tracking, and so it's looking like the normal 2:1 block that you know of. So this is happening because of pacemaker. This is a pacemaker 2:1 block that's going on. The other one is the Venn-Kebab behavior. So that means in this case, the 2:1 block will happen if the patient's sinus rate is faster than the TARP rate. Then the 2:1 pacemaker block happens. But when the patient's sinus rate is faster than the upper tracking rate, but slower than the TARP rate, then what will result in is Venn-Kebab. And this diagram will explain it more easily, which we actually saw a little earlier when we talked about the upper tracking rate and its behavior. So here, the sinus rate of the patient is 110 beats per minute. The timing is PP interval is 550 millisecond. And we have programmed an upper tracking rate of 100 beats per minute, which corresponds to 600 millisecond. Remember, this will happen in the ventricle. And on ascends, it starts a lower rate clock, which is not of concern to us at this point of time. So now it ascenses, starts an AV intervals, delivers a ventricular pace. Remember, an AV block patient. And on V pace, it started a PVARP, and also the upper tracking rate interval in the ventricular channel. Now, the next atrial event is 550 millisecond from this ascens, which is outside the TARP, because my TARP is 500 millisecond. So this ascens is outside the TARP. So this is ascens outside the refractory. My pacemaker had started an AV interval, which is 200 millisecond. So my AV interval expired here. So my pacemaker is supposed to have paced at this point of time, which it will not, because as we said, it will wait for the upper tracking rate interval to expire, which started with this V pace. So it waits for that to time out and paces the ventricle. So we are waiting 50 milliseconds longer. So my AV interval gets extended by 50 milliseconds and delivered a V pace. Now I'm delivering V pace 50 milliseconds later. So I'm starting the PVRP also 50 milliseconds later. Because I'm starting this 50 milliseconds later, the same sinus rate that is happening at 550 millisecond, the next P wave is likely to fall inside the PVRP. Right? So now my patient is an AV block patient. This is a refractory atrial sense. So this will not start an AV interval and it will not deliver a ventricular pace. Now I'm sure you recognize what's happening. Normal AV interval with ventricular pace, extended AV interval with ventricular pace, one P wave does not result in a ventricular event. So normal AV interval, prolonged AV interval, one P wave without a QRS. So that's the Venkibach, which is happening because of the interaction of the pacemaker timing. So which is the pacemaker Venkibach or pseudo Venkibach that's happening. So in this case, if we want to track this, we want to program a slightly higher upper tracking rate, faster than the what we have programmed here. It could be 110 or 120, but beyond a certain limit, it will result in a 2:1 block. Then we may have to also be concerned about what PVARP that we have programmed, and in this case will be, it will result in a 2:1 block if the sinus rate becomes faster than 120 beats per minute, as we saw in the previous slides. So that ladder diagram might look like this: ascens, V pace. Normal AV interval, ascens, V pace, because it started an upper tracking rate interval from this V pace. So it waited for that to expire. Otherwise, my pacemaker would have paced here. And the next atrial event also is here. Based on my programmed AV interval, I should have paced the ventricle here, but the upper tracking rate interval has to expire, and that's why it waited for that. So that prolongs the AV interval further. So now it's normal AV interval, extended AV interval, even more extended AV interval. And because of this delay, the next sinus rate, which is at the same rate, is falling inside the refractory period, which is not tracked and paced in the ventricle, and the sequence continues. So this is the pacemaker Venkibach. In this case, as we said, we want to program a higher upper tracking rate, and at that point, we may also want to be considering reducing the PVARP. So if you want to remember it, the way to remember it is 2:1 block will happen from a pacemaker if the atrial rate is faster than the TARP rate. Venkibach will result if the sinus rate is faster than the upper tracking rate, but slower than the TARP rate. And it is ideal to have the pacemaker progress first of all up to, give the proper physiological 1:1 tracking sinus rates, and then beyond that you program in such a way that the pacemaker progresses to Venkibach and then progresses to 2:1 block, so that there are fewer symptoms for the patient and the patient can adjust himself. So let me skip this calculation. So yeah, so then if you go back to once again the CRT patient who was on treadmill, which resulted in Venkibach, then also in a 2:1 block, if you program the PVARP or the upper tracking rate appropriately, now you can allow a reasonably higher upper tracking rate, which you consider as physiologic for this patient, resulting in ventricular pacing, which will avoid symptoms for the patient. And that's how you may want to program. So to do that, you may want to consider programming a higher upper tracking rate and also reduce PVARP. And when you reduce PVARP, you are now running the risk of encountering pacemaker-mediated tachycardia. So in order to avoid that, you could consider shortening the sensed AV interval. In the current pacemakers, as we will see later, there is a rate adaptive AV interval is available, and also in the current pacemaker, automatically adjusting PVRP. The pacemaker will maintain a longer PVRP during the slower sinus rates, and as the sinus rate increases, then the PVRP will automatically reduce gradually. So usually when the sinus rate is faster, the chance of pacemaker-mediated tachycardia becomes lesser because the chance of retrograde activation becomes a little lesser. So that's the programming options that are available. And these days you do not see much pacemaker-mediated tachycardia. So you can program a reasonably good higher upper tracking rate, because at nominal settings, these are all automatically taken care of. So you need to keep all these in mind only when you encounter a younger active patient where the sinus rates are higher and you want to actually track them so that the patient has a better quality of life. So in a normal pacemaker age group of patient who will be 65 or older, the nominal settings will be appropriate. The upper tracking rate will be 130 beats per minute, which will give actually 1:1 tracking. And then when the sinus rate is between 130 and about 150 beats per minute, it will provide Venkibac. And when the sinus rate goes above 150 or 160, the pacemaker will exhibit a pacemaker 2:1 block. So at nominal settings, in a normal pacemaker age group of patients, you need not worry about all these behavior. You need to keep in mind when you are looking at an active patient where you want to track physiologic sinus rate, and also a younger group of patients. And then a little note on the upper sensor rate in a dual chamber pacemaker. Everything is the same as what we discussed about in a single chamber pacemaker. The only difference is the sensor inputs results in a high rate of pacing in for the pacemaker, but what it will do is it will actually pace the atrium at a faster rate. So now we are looking at atrial based timer. So this is my lower rate. I'm delivering a pace here, start an AV interval, pace the ventricle. At the expiry of lower rate interval, I deliver a pace one more time. I start an AV interval, pace in the ventricle when the patient is at rest. Then you have programmed an upper tracking rate, upper sensor rate, or the upper activity rate. When the patient is maximally active, then in this case, the pacemaker will pace the atrium based on the input from the piezoelectric element. It will pace the atrium at 120 beats per minute. And on every time it paces the atrium, it starts an AV interval. At the end of AV interval, it will do a ventricular pacing. So that's the behavior of the upper sensor rate in a dual chamber pacemaker. But the function of the piezoelectric element and the way that it results in an increase in the atrial rate or the rate of the heart is the same as what we discussed in the single chamber pacemaker. And if you want to, relook at the difference between the upper tracking rate and the upper activity or the upper sensor rate. Upper tracking rate is the rate, the maximal rate ventricle will be paced in response to atrial sensing. So here, atrial pacing is not a consideration, which means the ventricle will not be paced faster than that rate, which is a programmable rate. The nominal settings are 130 beats per minute today in most pacemakers. So that means up to 120 or 130 beats per minute, there will be 1:1 tracking and pacing of the ventricle. When the sinus rate becomes faster than 120 20 beats per minute in this case. Up to the TARP rate, it will provide Venkibach, and beyond that, it will go into a 2:1 pacemaker block. That is when it is sensing the atrium. Now you're looking at the upper sensor rate in a patient that has a sinus node dysfunction and chronotropic incompetence. Then you may need to pace the atrium at most of the time. Then there is no or unlikely to be atrial sensing happening. Then the patient's increase in heart rate depends on the pacemaker sensor indicated rate. So that means you're pacing the atrium at all times. So then you are pacing the atrium at a sensor indicated rate up to the upper sensor rate, and that will start an AV interval and pace the ventricle. And usually the nominal settings is both the same. Upper activity rate and the upper tracking rate is the same at nominal settings. But you could program either higher upper tracking rate and a slightly lower upper sensor rate, and vice versa as well. And it depends on, in most of the cases you encounter, in a lot of cases, patients with good sinus node function and AV block, then you want to track and pace the ventricle. And if the patient has a pure sinus node dysfunction and then AV conduction, then the 2:1 block is not a consideration, because AV node is going to be conducting in that case. But it becomes a confusion sometimes when the patient has both sinus node dysfunction and AV block, or intermittently both of them. So that is when you need to be keeping these two in mind. But if you look at these two separately, upper tracking rate comes into play when atrium is being sensed. Upper activity rate, upper sensor rate comes into play when atrium is paced. When you keep these two in mind, then programming and occasional troubleshooting becomes easier. So that completes the dual chamber timing cycle. I can understand it's quite fast paced, and it could be slightly confusing. I stop here to take questions, and also before that, some comments from Dr. Raja before taking any questions.
Thank you, Govind. That was comprehensive. And I know, like you said, and there's a comment here also saying that it's a little difficult to follow, but that's a little difficult to avoid with this kind of topic. Like I said, there would be people with who are at different levels of understanding. So there are people for whom at least the single chamber timing cycles they're very comfortable with, and it is important to cover dual chamber timing cycles with them. There are other people who are in the beginning of their career, and there it's important to emphasize the single chamber timing cycle. So I think Govind did a good work of balancing everything, and he covered a lot of very clinical points also. Like, we can probably re-emphasize that as we discuss some questions, if there are questions. But don't think you have to follow everything that was said. As long as you understand at least understand some of the things that were discussed, it will help you when you follow up patients. And many of these things will be reviewed when we probably in the next session when we discuss follow up and troubleshooting also. So don't be discouraged thinking that a lot of this you could not follow. There is it's sort of one of the disadvantages of a virtual platform like this, with the time limit, that we don't have a lot of interactivity, and we don't have the comfort of stopping and discussing a lot. But I think that is understandable. So I think we'll take questions for about 15-20 minutes if there are questions, and both Govind and me can discuss something.
Okay, so there are a few questions on the question and answer box, and actually all of them, the first three questions, first and the third question is actually, saying that yes, it was a slightly fast-paced, monotonous lecture. Apologies, and this happens in this kind of a lecture, as Dr. Raja also pointed out. And the other is one explanation of Venkibaching. Please enumerate pacemaker-induced Venkibaching, which, as I said, is when the sinus rate is faster than the upper tracking rate, then the pacemaker cannot provide 1:1 tracking, and then the ventricular channel starts the upper tracking rate interval. So the next ventricular pace will have to wait till the expiry of the upper tracking rate interval that started with the previous ventricular event. So that allows the extension of AV interval. which will behave like a Venki box, and that's why it's pacemaker Venki box. And I did show a couple of examples. Maybe during the troubleshooting, we will see some more of that. And then the other question, when should we program MTR and MSR differently? When to keep MSR higher? I would request Dr. Raja to comment on that.
I think Govind covered it to some extent, but so essentially you think what you want to do. Obviously your MSR, or what he discussed as the activity rate, is basically what you want to set as the sensor rate. So that is the rate at which you want to, in a dual chamber device, you want to pace the atrium. Whereas the tracking rate is basically what you're saying, that with a sensed rhythm, when do you want to track, how fast do you want to track in the ventricle? So the MTR is more important in a clinical setting where there is a normal sinus node and there's an adequate chronotropic response. So it's a young person with, say, AV block. And if he goes and plays basketball, his sinus rate goes to 140, you want him to track. So that is where you're thinking about tracking rate. Whereas the sensor rate becomes important in somebody with chronotropic incompetence or sinus node dysfunction. So if you implanted a pacemaker in somebody with sinus bradycardia, so that when he goes to play basketball, his sinus rate doesn't go up, it only goes to 80, there the tracking may not be important because his AV conduction is normal, and then it's what is important is the sensor rate. So there you want to keep a higher sensor rate. A younger person has physiologically a higher heart rate with exercise. So you set your sensor rate similarly. You can set your sensor rate based on these usual like age related rate calculations like we do on treadmill, like 220 minus age. But usually we don't go that radical. Like Govind said, for most younger people, 130 is also sufficient. But for young people, children, you often have to set a much faster rate. So you just have to be aware of that. And so Vatsal again is asking, when programming blanking periods, what are the usual values and guiding principles? So blanking periods, most are sort of fixed, only some are programmable. Most of the time, unless there are specific issues, we leave it at nominal settings or this. Govind, do you want to say anything about the blanking periods issues? Very rarely that we have to program around that or change it.
Yes, agreed. It's extremely rare that we touch a blanking period. Both the only programmable blanking periods are post-atrial ventricular blanking period. The other is post-ventricular atrial blanking period. So in 20 years, I have not had an opportunity to program these two values.
Correct. So blanking in the same chamber is not programmable. The cross blanking, like you blank in the atrium with ventricular sensing and blanking in the ventricular with atrial sensing, is programmable, but almost never you have to touch it. So you don't do anything with that. And so there's another question in the chat box about when should we opt for VDD versus DDD. So again, I thought Govind discussed that well, because so the issue is that a VDD and DDD, what is the difference? The difference is that in a DDD, you pace the atrium, whereas in the VDD, you can only sense the atrium. So you can, and what is the advantage of a VDD over DDD? One is that you can do it as a single lead. If you use a single pass lead, you can do it with two leads also. And the second, like Govind mentioned, is that the devices, now it's becoming less common to find even VDD devices, or they give it at almost the same cost. But theoretically, at least, you can have a VDD device which can be a little simpler and cheaper. So you can have a cheaper device and you can use a single pass lead. So those are the advantages of VDD. So you can prefer that in patients where you think you want to have tracking of the atrium, but you don't think you're going to need pacing in the atrium. So actually it applies to a lot of patients with heart block. Many of the patients with complete heart block have a good sinus node function. If you see that their sinus rates are good and you don't think there's going to be any chronotropic incompetence, their sinus rates will go up normally, you can put a VDD device also. But if you put it as a DDD also, you essentially program it such that it functions as VDD most of the time, which means that we put a lower rate and you usually put rate response off. So in somebody with a normal sinus node function. Yeah, I mean, anything else if you wanted to add, Govind?
No, sir. So that was perfectly a clinical thing. Yes, nothing to add anymore. Okay, so there are no other questions. I can understand, because it was quite fast-paced, I was conscious of the time as well. In a normal in-person course, we do this for about 4 hours or so. We can go at a slower pace. So apologies for that.
No, I think a lot of this will be revised and more practically shown the next session. So don't worry about that it looks this. If you want, you can just sort of read it up once more. And in the next session, the troubleshooting and follow-up is mostly going to be based on this. So it will all be revised. And so I think it'll be fine.
Yeah.
Okay. We have come to the end of this session. Thank you, Govind, for excellent presentation. Thanks, sir, for your valuable inputs. We would be catching up next weekend, same time, 7 p.m. to 8:30. Only there is a slight change which I would like to share towards the last session, which has been as of now planned on the 14th of November. Because it is coming on the Diwali weekend, we would be naturally postponing this to the one weekend further. That is on 21st of November. So that's the only thing. We would be sending across the invite, the change dates and all, maybe in a couple of days. So that's the only change which is there as of now. Rest remains the same. So have a safe weekend. Catch up. We'll surely catch up next weekend for the fourth session by 7 to 8:30 p.m. Thank you. Thank you all.
Thank you all for joining. Thank you, sir. Dr. Radha. Thanks very much for being
Thank you,
here.
and good night, everyone.
Thank you.